Good evening, everyone. I'm Bruce Hobson, the Medical Director at UBC CPD, and I'm happy to welcome you to this webinar on systemic racism in healthcare, the unspoken bias and its impact. We have an exceptional panel of specialists and family physicians tonight who will answer your questions. But first, I'd like to just begin by acknowledging that the land on which our UBC CPD office is located is the unceded territory of the Coast Salish peoples, including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations. I personally am speaking to you from Quamachin Lake in North Cowichan, the traditional home of the Quamachin tribe, one of the 7 tribes of the Cowichan First Nations. We'd like to thank the Child and Youth Mental Health and Substance Use Community of Practice, an initiative of the Shared Care Committee, a joint collaborative committee of the Doctors of BC and the BC government, for providing funding to support the delivery of this webinar. This is a 90-minute webinar, and I encourage you to participate in the question and answer during the presentation, as this will drive most of what is discussed tonight. We'll be using slido.com to answer your questions. Please go to www.slido.com and enter the event code, capital M, May 1010 webinar. That's capital M, AY 10, capital WEBINAR, which was included in your email invitation to this webinar. Please upvote questions suggested by others to increase the chances of having them answered by our expert panel. We will try, but may not be able to get to all the questions in the allotted time for this webinar. So this webinar is part of a series of webinars delivered in partnership with UBC CPD and the Child and Youth Mental Health Substance Use Community of Practice. We have previously delivered a webinar on Indigenous specific racism, which was addressing anti-Indigenous racism in the BC healthcare system. And the recording of this will be shared to you via email. If you're having any technical difficulties, please note that the webinar will be recorded and will be shared together with a link to all the resources mentioned and a summary of key pearls to everyone who registered online. Finally, at the end of this session, please remember to take a few moments to complete the attendance and evaluation forms. In order for you to obtain study credits, you must complete the online attendance form. And you can access these forms via, again, the email link that you had received for this session. So as the COVID-19 pandemic continues to evolve, UBC CPD again wants to specially acknowledge and thank the thousands of UBC faculty members, medical residents, and other healthcare professionals and frontline staff who are working in extraordinarily stressful conditions in the healthcare system in order to provide the best care possible. We know that many of you are in the audience tonight, and if this stress is becoming overwhelming to any of you, please talk to a colleague or call for help through the Physician Health Program at 1-800-663-6729. We can't thank you enough for your efforts. This free webinar tonight is being offered with that in mind. And that number again to call, 1-800-663-6729. So let's get started with this session. Our panelists tonight are Dr. Ramneek Dosanjh, Dr. Jaswant Guzder, and Dr. Tatiana Suntinjo. So please take a minute to review the disclosures for the webinar. There they are. Thank you. There are no conflicts of interest, and any funds received by our panelists are unrelated to tonight's webinar. I'd now like to pass you over to our moderator for tonight, Dr. Shirley Z. Shirley, over to you. Please introduce yourself and take it away.
Thank you, Bruce. I'm very pleased to be presenting this webinar, which the goals are to define systemic racism in the context of healthcare, describe the impact of systemic racism on the health of marginalized populations, and list steps to take in your own practice to address the impact of systemic racism. My name is Shirley Z. I'm a family doctor in Kamloops, and I'm the current co-chair of the steering group of the Child and Youth Mental Health and Substance Use Community Practice and the chair of the ACEs Working Group. I want to acknowledge that I am moderating from the lands, the unceded ancestral territories of the Secwepemc Nations. And our first speaker that is up is well known to all of you, Dr. Ramneet Desange, our president of the Doctors of BC, and she will present the compelling reason why we have to address this issue at this time. Over to you, Dr. Desange.
Well, thank you very much for that warm welcome, Shirley. And I can't express that sentiment that Dr. Hobson so carefully articulated. And with that in mind, I do want, again, to acknowledge all of the work that's being done in this area and the privilege that I have been asked to be able to participate today on this very day. I'd like to begin by acknowledging the land on which the unceded territory of the Coast Salish people, including the Musqueam, Squamish, and Tsleil-Waututh that I join you from today. I recognize I'm a settler on these lands, and I'm committing myself to a journey of reconciliation and understanding the truth of all the Indigenous people and those that I am continuing to learn from. I also want to acknowledge today that last year on this very day, is May 10th, 2021, was a day of action against anti-Asian hate crime. And it became a nationwide proclamation, and it started by a group of grassroots activists in our very own Burnaby, BC. What I want to share with you today is just an overarching, some thoughts and sentiments, and what I call my ABCs of anti-racism. A quote from Dr. Abraham Kendi, who I have had the pleasure of listening to and read his books and his commitments to this work and acknowledged today in front of all of you. What is the problem with being not racist? It is a claim that signifies neutrality. I am not a racist, but neither am I aggressively against anti-racism. But there is no neutrality in the racism struggle. The opposite of racist is not racist. It is anti-racist. What is the difference? One endorses either the idea of a racial hierarchy as a racist or a racial equality as anti-racist. One believes problems are rooted in groups of people as racist, or as anti-racist locates the roots of problems in power and policies. So my first letter is my next slide, is awareness. When I speak of awareness, is understanding our current landscape and the landscape of colonization in our very backyard. I think there's a definite understanding our own lived experience, my own personal experience, and as many of you have experienced probably firsthand, the racism that does permeate through our healthcare system, but also in our society. And today, as we honor this commitment of our own awareness and opening our eyes, because our medical learners have also indicated that they have participated in racialized settings and have felt oppressed in their own academic learning environments. I also urge you to look at the social construct that permeates not only our system, but our delivery and our patients' lives and the encounters that we've seen. We've seen COVID-19 and all of the anti-Asian hate crimes that have increased by exponential amount. We've also seen and well aware of the In Plain Sight report prepared for a perspective and an insight into the Indigenous peoples and their journey. While I do believe that we are moving towards a direction in which we can have this dialogue. The first begins with ourself and our own recognition and our own participation in events like tonight, and maybe bias training or opportunities to reflect and sit with other cultures other than our very own to gain understanding and perspectives. I also want to think about the BC Office for the Human Rights Commissioner highlighting the grandmother's perspective, and the report prepared by our very own BC Centre for Disease Control and COVID-19 Anti-Asian Hate Crime. The proclamation on May 10th of this last year in 2021 was the Stand With Asians Coalition that was formed with a community of people in Canada who were concerned of the surge of anti-racism right here in our cities. Vancouver had seen a staggering 700% increase. While I don't need to stand before all of you and profess what has transpired, I do want to embed this within the framework of our understanding and our awareness. We've attached this in our references as well for all of you to have access to. The next slide in my ABCs of anti-racism, which seems really simple, is anti-racist action. As Ibrahim Kendi describes, the only way to undo racism is to consistently identify and describe it, then dismantle it. Informing policies, confronting power dynamics, giving a voice to the most marginalized and racialized minority, learning about truth from those populations, their perspectives, and their lived experience. Journeying in steps towards decolonization of our own participation in hierarchical structures and systems, and changing the way that we participate. Certain actionable items that were shared from our own learnings with the BC Centre for Disease Control have been actively address the racist discriminatory acts, including creating effective strategies for non-visible minorities to be the allies with this work, to ensure easily accessible, understandable, and culturally relevant supports, including translated materials that are widely distributed, using interpreters and our translators within the hospital or in environments where we may not speak the language of our own patients. This is also very important to address concerns of misinformation. We must stand up and challenge the untruths that have been spoken out and confront those with misinformation or bias. We need to increase our availability, culturally safe, relevant, and appropriate health services. And by this, I mean, is meeting our patients and our collective where they're at. I also think it's really important to enhance anti-discriminatory and intolerance-related content in our educational curriculum at all levels of schooling, including our medical textbooks. I also think that we need to create safe spaces for dialogue in our inpatient settings and be welcoming of all walks of life and all cultures and making them more inviting and safe. The next slide I have on my third and final A is anti-racist allyship. Simple concept. And within this umbrella is, again, advocacy and activism. I believe that we have the power to change the system and to influence the culture like we never have. I'm very grateful for this opportunity to even speak to you with the UBC CPD office and the way that we're moving forward. But I challenge you for your own spheres of influence to take all of your learnings and to impart them within your homes, within your schools, within your clinics, within your hospital environments, but most importantly, in your neighborhoods. We know the most powerful spheres of influence are who the people that you surround yourself with the most. And who better than the physician leaders on the ground to be telling this information, sharing this really important information, and creating allyship within our subgroups and our most marginalized patient populations. The next slide. My B's in my ABCs is bias and bystander. By now, most of you probably already know your inherent bias. And if we don't know, And we all can proclaim ourselves as anti-racist, but we also need to acknowledge our own racist and racial bias in all of what we do. And if everyone says that they're not, you should take the Harvard implicit bias course or the Center for Diversity and Inclusion. There are many aspects in which we can confront our own bias. And as sooner we learn about it, the less harm we do for our patients and the care that we provide. And I'm speaking to the B of bystander. I urge everyone's participation on this call today and in our learning that we stand up, we become the upstander. Because if we, with such power and privilege in the roles that we play and how we participate in our patients' lives, if we don't stand up, who will? And this goes to our next slide of C, which I didn't add it under here, but when I think of C, I think of courage. Culture change requires courage and compassion. And I am in a great environment where I'm surrounded by such amazing people that are participating in ways of outstanding leadership. I feel very privileged to be able to be in a position where I'm leading all of you in the sense that we are moving in a new direction. And by that, I say that we are going to confront the culture change that needs to happen. We will no longer put up with what has got us here in the first place. And the fact that we are embarking on this journey is a very exciting time, because I do believe it takes all of us in partnership with our allyship and to understand our marginalized populations, because our patients deserve that type of care. With further ado, I'll pass it back to Dr. Z. Thank you.
Thank you so much, Dr. Desange. Thank you for framing and opening webinar with the ABCs of why we need to address this issue now. Now we transition to Dr. Tatiana Sotinjo, who is a pediatrician and clinical instructor with the Division of Adolescent Medicine and Division of Pediatric Infectious Disease with UBC. Over to you, Tatiana.
Thank you. It's my distinct pleasure to join such a panel tonight and discuss such an important topic. I want to begin by outlining some of the goals of our brief time together, helping us to understand the developmental trajectory of race-based discrimination and bias, identifying racism as one of the adverse childhood experiences, and helping us understand the physical and mental health consequences across the lifespan. And finally, concluding with some complementary anticipatory guidance to Dr. Desange's suggestions in the ABCs of anti-racism. So one must first understand that, like all things in the evolving childhood, racial identity follows a course along a developmental trajectory. That is to say that children as young as 3 are able to identify physical characteristics that they may notice as different between individuals and groups of people. Later on, children may become aware of social groups and recognize in-groups and out-groups, and may start to develop prejudices based on their exposure to those around them. Later on, they can learn even more nuanced perspectives, but more importantly, they are capable of understanding others' perspectives, and empathy may emerge at this age. By the time one reaches adolescence, prejudices and biases may well be quite solidified. And interestingly enough, we often reserve discussions of race and bias until quite late into adolescence. So, is racism an adverse childhood event? Yes. Without reaffirming all of the information that we know about adverse childhood events and their long-term health outcomes and consequences, one can qualify racism as part of the emotional and psychological acts of abuse and neglect on the psyche of the evolving and growing childhood and adult. Racism is also often complemented by other acts of aggression, such as community violence, or the marginalization that comes with uncertain citizenship status, being a victim of geopolitical conflicts, or being a particular target of explicit acts of terrorism. So how does this begin, and when does this begin? Well, the story starts even from our various early conception. As a pediatrician, I understand that childhood begins not only at the birth, but in the intrauterine environment. So maternal experiences of interpersonal discrimination are associated with increased risk of preterm birth and low birth weight. It is thought that the mechanism is modulated by higher levels of cortisol. This extends not only to the clinical outcomes, but even from an epigenetic perspective with shortened telomere lengths. As you will recall, they are a marker of accelerated aging. So how do we get there clinically, and what are we to make of this? This is a headline from a CBC News story. In fact, it reflects American data. From 1992 to 2015 in Florida, upon review of 1.8 million hospital births, it was found that infants of African Caribbean or Black descent were 3 times more likely to die when they were cared for by a physician that was white. So how do we get there, and how can we explain this? Well, the story of racism and its effect on health doesn't begin at an individual's birth. The story of racism and how its toxic effects affect health outcomes begins even earlier with the previous generation. And what are we to learn about our American colleagues' reality? Well, unfortunately, here in Canada and specifically in BC, it is very hard to know. In fact, specifically to the issue of African Caribbean Black children and their birthing individuals, we have a lack of racialized data. And this lack of disaggregate data makes it very difficult, as one of our colleagues here addressed in an editorial to the BC Medical Journal, the true realities of what Black women's health is. And so if we don't have the data, we don't know the truth. And if we don't know the truth, it's very hard to make evidence-based decisions. So as this progresses from the womb to birth, infancy, and into childhood, the effects of racism and race-based discrimination have an effect on developmental outcomes, from academic achievements to access to developmental services, and even the ways in which children behave, either with increases in anxiety or with increased externalizing behaviors, which are the child learns to adopt as a means to protect themselves from the environment. Later on, these might become more solidified into what we would classically describe as psychopathology. How do we know this? In 2019, the American Academy of Pediatrics published a scoping review of the impacts of racism on child and adolescent health. This is a comprehensive review of the large body of literature that we have, contending that, in fact, even if children do not directly experience racism themselves, they can experience the adverse physiological and psychological responses. This makes sense. Some of us, including myself, feel like we're blushing, even just looking at someone commit an embarrassing act on television. So imagine when the stakes are even higher. We have now the evidence to show that the effects, what we see and what we fear, can have a physiological change and a psychological impact. This is Lucas Echaquan. He's one of Joyce Echaquan's children. I think it is undeniable that we can say that the anti-Indigenous acts of racism in healthcare have had a direct physiological, psychological, short, and long-term impact on his health and well-being. And he is not the only child in such a position. What about just the fear of racism and race-based discrimination? In fact, it's harmful as well, and it undermines resilience, hope, and motivation. This may explain why we have findings such as this one outlined in the Lancet, that police killings of individuals of certain ethnicities, when they are experience can lead to an increase in poor mental health descriptors and sentiments in certain racialized groups. We know also that incarceration of parents is another way that race-based discrimination and bias show forth. Young adults whose parents have been incarcerated during their childhood are more likely to skip medical visits, misuse substances, and have higher rates of sexually transmitted infections. In Canada, I want you to reflect on the fact that Indigenous women account for about 48% of the population in women's prison. A large percent of those women will be mothers. So the sources of racism are external and they're also internal. Perhaps that's why we can explain that Asian American young adults have suicide as the #1 cause of death for young adults aged 15 to 24. And what's the big difference? Well, when we fall or we break or injure ourselves, we are validated, we have a vocabulary, there's compassion and understanding. Racial aggressions. It's not unusual for someone to hear the equivalent of, you shouldn't have stretched out your hand and it wouldn't be broken. Maybe your radius should have been thicker and it wouldn't have happened. Or I'm sure the ice didn't intend to make you fall. So in summary, where do we go from here? If racism is an adverse childhood event, then it needs to be complemented or counteracted with positive childhood experiences. Anti-racism is an integral part of these positive childhood experiences in intervening to protect communities and historically marginalized communities in meaningful ways and interventions, so that our children can follow a developmental trajectory of understanding race and anti-racism in something that is meaningful, comprehensive, and that they see themselves reflected and discussed in the community and not left as a mystery to themselves. So in conclusion, race-based discrimination has a developmental trajectory. It's an adverse childhood experience and has physical and mental health consequences across the lifespan.
Thank you very much, Tatiana, for providing all the evidence behind how racism is a systemic ACE on top of the common ACEs that we know about, and how important as healthcare providers we need to pay attention to ensure that our patient's outcome is optimal rather than actually advancing the negative adversity in that space. So thank you very much for presenting that evidence for us. Now we turn to Dr. Gazda, Jasmine Gazda. She is a professor in the Department of Psychiatry at McGill University, and she's presently on leave and working in the Indigenous Child and Youth Mental Health Services with South Vancouver Island. So over to you, Dr. Gazda, to present on this topic that's been decades of your work.
Thank you. I want to acknowledge first that I have now moved to the territories of the Coast Salish people, where I live and work and was born. I am very grateful for the chance and opportunity to speak to you as a racialized minority in BC and having grown up here for 3 generations. I'm very moved to participate in this. We're all very grateful for the idea that finally out of this darkness of COVID has come a gift of being far more aware of what the lack of data, which has been referred to, what kind of issues are facing us in institutional racism. And cultural safety and cultural humility are key terms for that, that very complex predicament of trying to look at our ideas about power and the commitments of institutions and assumptions, which are then internalized over long periods of time. And as Tatiana has said, right from the beginning of the individuation of children, from the before the attachment, ethnicity is very important. So cultural humility is something that we have to make a lifelong commitment to, and calling out on anti-racism is part of that new structure. And this is really based in our medical practice on listening. In fact, our patients are our teachers. Cultural safety is only going to come as a created ideal if we are going to actively look at co-constructing with our patients, attentive listening to their needs, and thinking about language skills and dignity and taking time in a system which often, as we have understood, especially during COVID, has been very, very overburdened. So cultural humility is crucial to the person-centered care that we all aspire to hope for, to be comfortable with not knowing and to be open to the fact that traumas, especially traumas of racism, are very slow to be shared. And we must strive for some kind of attunement and involve our look at our listening. Do we pause? Do we wait? And do we observe? Do you see me and do you hear me? This is a very important part of this. And part of what we also have seen in my experience in clinical work, especially with children and families, is that dissociation and blankness can often occur for a very long time with a patient before we actually meet the real person. We know that the cultural formulation work that has been done, but in the DSM is something that was put in the last pages of the DSM-4, is now now officially in the DSM-5. But to integrate this into training and to give our young people a chance across all disciplines to learn how to think in a different way to construct what we are experiencing is very crucial. It comes back to the delusion of neutrality. Now, I was trained as a psychoanalyst and a family therapist. I run a department in child psychiatry, and I am really quite perplexed and excited that at this time, at least, we are finally looking at the issue of internalized racism and our colonization. And this kind of delusion that we are neutral because we are physicians is something that has now, I think, certainly been unmasked. Being aware that cultural diversity is about complex hybridities and that we have to accept the position of never assuming that we understand and know the complexities of the ancestry and basis of identity of our children and our families that we see. We're asking to look at stereotyping as something which can erupt at any time. There was a lovely vignette in a previous seminar where a physician in the emergency room made a spontaneous decision not to treat first an indigenous man who had come in with a fairly severe wound when she saw also a young child who would have had to wait a very long time, she thought in her mind. And she turned to the young child first and asked this gentleman to wait. And a huge eruption took place. And that was learning from a patient. She said, what she had to understand is the assumption of how many years of this man's life and ancestry were related to racist experience. These are chances for us to understand that children and families tell us things indirectly. Sometimes, and I have treated mothers where they are possessed by spirits or jinn, they would never speak to their physician about such a thing. They're quite terrified of the stigma of it. So to be able to create enough safety, to be able to share those issues is extremely important. Micro and macro aggressions cause chronic distress, not PTSD necessarily, but chronic distress that goes into the body and into the psyche. So it is a question of how we are heard, and we have to let the patient set the agenda when it comes to these kind of issues and the pace at which they are prepared to speak and share this with us. And these emotional signals from our patients that their internal discomfort often means we need to slow down. And we are working in a profession which is pushing us over and over again to try to complete our work very quickly. This actually takes time. Micro and macro aggressions accumulate, and they have very traumatic influences. I remember many times treating refugees who really shut down and can't speak because they feel the doctor is not listening. Or having met many physicians who have really not recognized that they are encountering those kind of moments. So I appeal to us all to look at self-care as well, because to become vigilant and to take on an active anti-racism and allyship means that we must look after our own consciousness. And there was a beautiful example of this by a family physician in a recent seminar where she took a moment to actually brush off the last patient and do the mindfulness to be present for the new patient. And because we all carry very heavy burdens. So look at our power and privilege, our stigmas, our hierarchies, our silencing, the way we refuse to address anti-racism agendas, the spaces amongst our teams where we are allowed to share our moral distress and to help our co-workers to actually discuss these things in supervision and to look at the policies in our own hospitals and institutions and communities which contribute to this. So I leave you with Maya Angelou's quote, "People will forget what you said. People will forget what you did, but people will never forget how you made them feel." Thank you very much.
Thank you, Jasmine, for the powerful message that you sent us and all the pearls of wisdom from your years of work in this space. So now we're open to entertain questions from the audience for the next 50 minutes or so. And I have some already populating the Slido. So you can go there and ask questions or upvote the ones that are there already. So the first question is that I find that people who attend sessions such as this one are those already interested in the problem. It is a great space to share ideas. However, those who need this training the most, the larger part of the problem, don't often join. How can we increase physician training on systemic racism? So I am going to turn to Ramik Desange to start off that discussion. Over to you.
Sure, I'll briefly start that question. And I think this is the importance of where the action, the embedding in policies and confronting the power dynamics that exist. So really trying to embed this from our learning all the way from, in my personal opinion, public health and prenatal visits, all the way through the trajectory of our early childhood education, as well as our education system, as well as our undergraduate system, but definitely embedded in our medical learning, especially in the early years. I think it's really important, although we do have, the Gen Zers, and I raised one, so I know that they walk a little differently in the world, which is very, it's good to see that, because the way that they are informed is a little different than the way I was raised. And the confrontation, actually, even at the level, at the younger ages, I'm seeing it, that people are being more directive. And I think to instill change, we need to go across our own organizations. And I want to lead into Jaswant about this, because she has a lot of research on the institutions and how do we confront change into the institutions, and also the lived experience of Tatiana in the social pediatrics setting, another place where there's a captive audience, but to understand the social determinants of health and the layering of adverse childhood experiences, but really making our organizations feel that this is everyone's work and everyone needs to be an active participant. And what I can tell you from the Doctors of BC framework is that we've actually committed to the equity, diversity, inclusion work, and we are working on policy papers to create a gold standard. And I think that is in the professional realm, but what can we do before we get to that point? I'll pass it on to Jasmine.
I think this is a very active issue. We've already brought up the issue of a lack of data. That's an extremely important one. We started a recent research project in British Columbia to look at the effects of COVID, and we found there was a great deal of resistance by many people saying that if you collect racial this ethnic data, you're embarrassing and making people uncomfortable. And in fact, that's part of the issue of the privilege that we have of leaving things the same. I think COVID has inspired us somewhat to feel uncomfortable is normal. And that is that we have to embrace the work that has to be done. This is an appalling example, COVID, globally, not just in our country. And we are very privileged here. So this is going, and I do not think that we can be at all complacent. I worked in Quebec most of my life, and I can see the kind of rules and regulations which are coming, exactly what In Plain Sight has talked about. It's very obvious that the policies are there. It's very obvious in the resident training, in even in a way that we are able to conduct business in ways that are full of micro and macro assaults, and we have to leave these as unspoken and invisible. So I'm asking that we join together to encourage each other and support each other, because it takes a lot of courage to resist. And Tatiana, I think, has definitely something to say on this.
Thank you kindly. I think that moving towards a direction of applying anti-racism as a core competency, in the same way that confidentiality is a core competency that is expected of every trainee out of every program. Every specialty has its own delivery and mode, but the core concept of agency and benevolence and is core in every subspecialty. So I think moving the direction of this being a core competency in every subspecialty is really imperative. And so Dr. Desange and others are working on the systemic level, but on individual levels, I think each of us in our various corners and aspects and specialties and areas of passion within medicine can do that as well. And then finally, I think it's really important just to acknowledge the history in each of our areas of medicine, because if we don't really understand the history and how the implicit discrimination and bias has been embedded into our specific subspecialty, then it's very difficult for us to, take a step back. And that involves having people from all walks of life kind of have an honest access and to the table and being not just heard, but listened to.
Great. Thank you all for your fantastic answers. I like the idea of core competencies being embedded and that there's active individual work to get to the goal, to have that collective awareness. So the next question is directed to you, Tatiana, and others can comment as well. Dr. Sotinjo, you showed data that in Florida, Black children had higher survival rates when being cared for by a Black physician. How do you think this translates to care provided to patients of other cultures and or to care by care providers of the same gender?
Mm-hmm. I think this is a really great question. So I don't have the articles directly in front of me tonight, but we know that even in surgical specialties, that there is some evidence that female surgeons might have improved metrics than male surgeons in certain aspects of women's health care. And so we know that there is probably a lot of invisible dynamics that are at play, and it's not one single event. But what we can learn, and Jasmine has put this out very clearly, is that it's creating a space whereby both the clinician and the person seeking and family seeking care can feel comfortable, because it's often in the space where things are not said or people do not feel like they have the permission for things to be said or heard, that very relevant clinical information is missed. That's one aspect of it. And then when we think of the aspect of underrepresentation, we know that our workforce in medicine does not reflect the communities that we are working in. And so there is not a proportionality of representation as well. How it works with other cultures, I think it's very interesting. I don't think that we can necessarily copy paste the information from the US to our Canadian context and then additionally to the BC context. But then again, I think this is why it's so important for us to begin to have our own local disaggregate data to better understand this dynamic. Because it might be that we are implicitly doing things that are helpful, but it might be very well that we're doing things that are very unhelpful and actually harmful. And then lastly, also too, it comes with the issue of micro and macroaggressions it's relevant to the workforce itself as well, and not just to the clinicians that we are serving. We've seen with the COVID-19 pandemic that even gender itself, as far as rates of publications in peer-reviewed journals and burden of clinical care, it has not been proportional between genders, and likely has not been disproportionate burden and stressors on various genders or gender minorities. So I think the complexity of intersection is something that needs to be better understood. But certainly if we're able to address hypertension as something that is a complex psychosocial and biological phenomenon, then we can begin to address these kind of biases with the same approach, because I know it seems overwhelming, but so is hypertension, to be honest. And so I do think that we need to move towards diving deeper into the data in order to really understand our local lived realities.
Thank you, Tatiana. Jasmine, do you have anything to add?
Well, psychiatry has quite an important history of racism in itself. And I think we understand through the work of the Truth and Reconciliation Commission that we have had to face the fact that psychiatry and the mental health group made a lot of decisions and colluded with a lot of decisions which were extremely destructive. And it was really based on a kind of idea of a universal theory. That is that as though culture was not in flux, or the colonialism and its embedding did not exist in our rarefied and privileged world. And these kind of delusions continue to, unfortunately, to haunt us. And I think this is again coming back to the issue of how many children go into placement in certain ethnic groups, and what is the judgment on what kind of attachment is considered normal. All kinds of cultural adaptations which are simply really not addressed and not even taught. So we have to improve our learning, and we have to understand that medicine and listening is embedded in history, stereotypes. So even though there may be an Asian stereotype of the model minority, in fact, this is quite a burden. And if we know that every kind of ethnicity it enters our country, but we have very different responses as a nation to various groups. And we have a long history of Black racism in this country. I did not know that our Douglas, our first factor here in the Hudson's Bay Company, was partly Black until very recently. Our own history is very important in understanding what we do in psychiatry. And certainly any work in anti-slavery, in all of this kind of area, we have to dismiss this idea that that's all over and finished. What are you talking about? And I am really continuously dismissed amongst many of my medical colleagues when I talk about this thing. So we have to make that part of regular education. And I love this idea of Tatiana. This should be a core competency. I certainly endorse that. Thank you.
Great, Jaswan. Anything to add, Ramit?
I think I just want to add 2 points. I think one of the ones, just picking up on what Jaswant just said, is that if our colleagues are saying that there's not a problem, it's one of 2 things. It's usually they haven't seen it or they haven't experienced it. So the awareness speaks to opening our eyes to a different lens than just the one that we're inherited and that we're born with, because many of us are born with privilege. And I myself, like Jaswant, I've had intersectionality. So I have many aspects in which I've also experienced racialized healthcare and racialized delivery of healthcare, and also witnessed it as a provider. And I want to speak to the question is that think about it yourself. Who are you the safest with? Usually the people that are the closest or most like you. And usually it's within your group or your community, in your family, in your home, your neighbors. You feel safety and security with people that you know. And in order to share a part of yourself that's vulnerable, you usually seek out the person that's willing to listen, one. So that could be any race that's willing to accommodate and listen. And I want to talk about allyship there is because there are a lot of places that it's not the same race, but they understand the culture and they understand and to meet the patient where they're at. I worked in a very South Asian, heavily influenced, my own patient population. But I had women that had been seeing doctors in the community for many years, but only felt comfortable to come to me and share some women's health issues that were very urgent. And, you know, some other issues that they didn't feel safe. And it wasn't that they weren't getting care, but they just didn't feel that they could be open in sharing. And so sometimes it's just, it doesn't necessarily depend on who it is as much as how they show up and allow that patient to receive care. Because I have seen many providers and I've watched some of my own preceptors deliver some outstanding care, but they make themselves available to learning and to open-mindedness, and have created a culture and foster this ability to engage and meet the patient where they're at. So I think that's a fundamental truth, but think about who you're most comfortable with. You know, you're in a country where they try to force assimilation, and you're within colonized structures. And many of us have had those are of immigrant families and have witnessed that firsthand. But to ensure that we've got culturally safe and appropriate care, especially if there's a language barrier or an issue, especially with trust in our healthcare system. Our healthcare system has alienated a lot of populations and marginalized minority groups. And not until we take not only a document for the truth and reconciliation, but try to change the way that we participate and show up and allow ourselves to be vulnerable in the same way, do we really get to acknowledge and confront the problem? So I hope that helps.
Great. So we have a ton of questions coming in, and we have now very limited time. So I'm going to move through them fairly quickly and maybe direct one to each one of you. How can we better equip our patients to feel comfortable or safe in disclosing racist incidents in our own office? I'm going to direct that to you, Tatiana.
Sure. Okay, in 30 seconds. So first of all, I think that we have to acknowledge and ask how people identify. And I think the environments, our clinical environments, should reflect, should be welcoming or actually reflect the diversity of identities that we see. So just acknowledging that gives an opening to individuals. And then I ask, you would be surprised how many 7 or 8-year-olds in my clinical interactions, I just simply ask, have you had any people give you drama or hurt you or, say things about you because you're different? And, things will come out. I think as a institution, it's important to have a reporting mechanism, but then it's really important to have a reporting mechanism whereby people who understand the nuances are then responding to it. Because if it's just about responding, our families will continue to feel ostracized. Then we need to think about structures. Are our patient advocacy committees, groups, and consultation services truly reflecting the communities they are serving? On a structural level, we need to think about the community representation just as much as we need to think about individual patient representation. So that's kind of where I would start from a structural and clinical one-on-one circumstance, and ask. And I just acknowledge that sometimes I'm going to get it wrong, but I want to know when I get it wrong, and that we want to work towards helping things get better, because I know that these things might hurt you and your ultimate health, not just of yourself, but of your child and of your whole family. So that's why I'm asking, not to make you uncomfortable, but to work towards improving your health. And then at the structural level, I think that is something that we need to look at kind of globally. And if we center the most marginalized rather than centering the most common and obvious, then we will begin to be able to address the issues that are most relevant for those that are the most likely to experience the ill effect of race-based discrimination or bias.
Great, thank you, Tatiana. You went from individual level to systemic level for a system to truly do the work is to hear from the marginalized individuals in a safe setting, because there are lots of power dynamics when people are seeking care and they're afraid of speaking out in case it really jeopardizes their care further. That is a very sensitive issue for them. And for the people to actually trust the system is when they do speak out, they're heard, and there is continuous improvement based on validating what they say is true, and things are going to change for the better. Without that continuous learning and quality improvement framework, the people that speak out is going to feel even more unsafe in a system that's not designed to support them. So you outlined some really incredibly important steps that need to be taken. So that was done in a very succinct way. Thank you. So next we go to what can we do to educate our staff to examine their own bias related to race. There are courses available that we and our staff can take. Jaswan, you've been teaching in this space for a while. What can you say about that?
I think lived experience counts for a lot, and I really like what Tatiana is saying, that being in a team where you actually represent the patients that you serve makes a huge difference. And I feel that many of my teammates learn from those kind of interactions. I do not think that ethnic match is a solution. I think that it is about our internal reflective capacity and our capacity to learn from our patients. And when something untoward happens and the patient indicates to you that they feel hurt, don't dismiss it. Really try, if you can, to open it up and to let people know that this is something that you appreciate them telling you, that they feel offended. Thank you for telling me that is much more important than bewilderment and shutting down an experience. And this takes support. And this goes back to when we go to school, right from the very beginning of daycare, all of these accumulated experiences sometimes have to be unlearned. And I'm talking about all of our mental health professionals, how hard it is for them if they don't get that support from their team. I believe that teams are, and keeping teams healthy and promoting critical thinking without a punitive and negative, uncomfortable response is something very important that all of us are part of and responsible for. We have lots of data. We have reams of material to read. There is a long literature on this. This is not news to us. Okay, what is very clear is that there's a great deal of resistance to the change, and COVID may have helped us finally to amass something. Denial is a very, very big disease.
Thank you. Thank you, Jasmine. So the next question is, the burden of dealing with racism by changing behavior seems often to be directed to the people with a white European background. What do you think about this perception? Rami?
Well, I think that's unfortunate that that's the only perception out there. But I think many of us that have, been a part of what we witness as colonization of this land, and if we look at the truth of the Indigenous people and the genocide, and we think about it from a settler lens, there is that perception because that is what history has taught us. And what Jaswant says is that the literature shows up. And for all of those who have done the bias training, you'll understand the inherent bias is a white European male with blue eyes is who we feel safest with in the world. And the antithesis of that we're taught is a black man or a black male. And so this is a conditioned social construct. And unfortunately, because of that leading inherent bias, the work we do to decolonize structures and systems and our own frames of reference they may seem pointed. And I'm not saying that everyone is complicit or implicit in this. As Jaswant has said, that some of her colleagues are in a state of denial. It may be denial or a lack of awareness, because until we actually meet ourselves, I often say that we can only meet other people how deeply we've met ourselves. And I'll have to say, just sharing my own lived experience and my own evolution of this truth and understanding this bias training and how we've come to where we are. And the aspect of what they reference as a SWAM and some of this bias training is that adult male European settler, as they have the most infinite privilege because their worldly constructs are built around them. That's where it comes from. And when we commit to anti-racist principles, there is a lot of work to be done even in confronting that perception, because we have to be aware of all of the allyship and the work that's being done. But when it comes to people with lived experience, we're often the ones that people seek out to find and speak the truths of what is happening on the ground, whether to acknowledge it, to raise awareness, or to nudge us in the direction of, we're really not that bad. We have you here, we're pretty diverse. So we have to be very conscious of the perceptions, but those are constructs that are made by socialized environments, not just ourselves. And that's why I think when we make a proclamation together about confronting our own power dynamics and the policies that exist, we have to be aware of who they do benefit and how they've been constructed. And we have to acknowledge that the people in the present day may have not created those constructs or historically set up the colonizational structures, but we are active participants, myself included, until we make a conscious decision to lead every day with an anti-racist framework. We all are part of this work.
Thank you. So reinforces that it's individual and collectively we have to do the work, and it's ongoing, Jasmine. You had mentioned previously, it's not like one snap and you're totally reverse. It's a constant learning and working at it. The next question: how can white physicians best learn about the multicultural population they serve? Who can they ask questions about specific cultures from their experiences? Tatiana, would you like to tackle that one?
Sure. I think that as physicians, we want to strive to go to a source that is reputable, and also to look for tools where they exist. So, whether it's the New England Journal of Medicine scoping article on how to combat anti-Asian hate in our clinical environments, or the large body of literature on micro and macroaggressions in the medical education setting. Like these things are all available in peer-reviewed articles. So I would suggest, and my approach is to look for those resources. The more and more of them appearing in the peer review literature. For those of us who are interested in research, CIHR has some pretty clear indications on EDI and how to ask for ethnic data, how to interpret it, how to integrate the nuances of that. So I think those are really valuable resources rather than adding additional burdens on one individual person or entity. I think the In Plain Sight report is a seminal document that should be a go-to for turning to when it comes to anti-Indigenous racism. And then I think advocating on a system level for these policies or documentations to be readily available if it's through organizations like Doctors of BC or even the college. The fact of the matter is that, if I wanted to learn about heart failure, I wouldn't necessarily just ask one individual patient, but I might ask several patients and also complement it with best practice guidelines. And so I think I would encourage us to use that as a complement of the lived experience of those that we're around, also of our patient, but to be committed to continuously looking to the evidence-based literature and holding to account also our organizations to know the statistics and be publishing guidelines that are inclusive of this metric.
Thank you very much. You place it in asking, hearing, and also going to best practices in the literature, which has lots of resources for us. So this next one, I would give to Jasmine. How do we give agency to people on the receiving end of racism in the healthcare setting? Healthcare providers wield a lot of power in the patient-doctor dynamic. We know that. Should we look at redoing how healthcare services are delivered so that there's more flat, equitable relationship? Oh, just want to unmute.
So now we're coming to the issue of access and safety again. And I think that this idea, for example, of not really bothering to teach cultural formulation or to understand how we're all constructed through our systems, through our relationships, our attachments, but also through our ancestry and through the whatever grounds us. And this means that in a clinic where there are mainly Black children or visible minority children, and I have no one on my staff who is available to reflect that, this makes a very powerful statement to these children. And I think we have to encourage our students. If we have if Cornelia Wyman, in fact, had this experience of being the single pediatrician of Indigenous origin, and what a very heavy burden that is. So we're talking about dispersing that into training as an ordinary part of our understanding of what personhood is, and the flexibility of it in a diverse society. And if we don't do it for now, we are losing our children. This is very, very important. And it has to go into schools. In all the work we did in Jamaica on post-slavery trauma, primarily we decided the place to start was as early as possible. That is, it is in daycare and it is in elementary school. And it was more about changing teachers' attitudes and professionals' attitudes towards the children than it was anything else. So I think we have to think out of the box. I think we have to think about community and about the complexity of identity that is hybrid in a diverse society, is going to evolve through our whole lifetime. It's never going to be finished. There is no such thing. And the other part is we're so privileged, and we look at how we treat the rest of the world. And this is really, for me, incredibly underlining in medical school and in nursing and in social work, our partners, that we all need to have this discussion together. It has to be part of our training.
Yeah, collaborative, upstream prevention are some of the key words here. Thank you, Jaswan. So next question, we're privileged to have panelists of different races. I'd be interested in hearing some of your personal story, if you're comfortable with this, about how you've been affected by systemic racism. So this one, I would ask the panelists if they are comfortable in sharing, that they do share, because stories are extremely powerful. However, I would also, if you feel uncomfortable doing so, please feel that you can pass on this. So this is, I'm going to engage the whole panel to offer up personal stories if you wish to. So I see some head nods. Jasmine, you're brave enough. Let's have you go first. Unmute.
There are so many stories that come to my mind in growing up. One of them was as a child in elementary school. I mean, my family did not get a chance to go to school, so this was something incredibly important to me. My grandmother had been really psychotic by the time she settled in the island. She was so isolated and so depressed. And she endured ECT treatment without anesthetic, never left the island again. And it was a very, very huge influence in my life. And I remember how privileged I felt to be able to go to school. And the teacher telling me when I was a young girl, maybe 10 years old, and I was a good student, she asked me what I wanted to be, and I said, I want to be a doctor or an artist. And she said, well, I think you have to change your mind, because people like you don't become doctors and artists. And this stayed with me for a very long time, this shadow. And I realized even in my son's life, at this age, 3 generations later, the same kind of nonsense is going on, cruelty all the time, in offhand remarks without reflection. So perhaps part of this discourse is about the reflection for me, but the experiences, I have many, Shirley. Okay, thank you.
Thank you for sharing. Thank you. And I think that was a large motivator probably for you to go into psychiatry and to change some of those perceptions. Rami, I'm turning to you. Do you want to share?
Wow, I think if people know a little bit of my background, obviously I come with the whole gamut of intersectionality. And yeah, I was born and raised here, but my parents both weren't. My father was an immigrant from New Delhi, came at the age of 24 here, and worked at 75 cents for the hour when the non-racialized people worked for $1.50 an hour. So it began early, and my dad was a master's educated in economics, and none of his degrees, even though he went to Delhi University, one of the most prestigious in India, all of his credentials were denied. So he wasn't able to ever have professorship. Didn't stop him. He still ended up working for the university many years later. But it's kind of rooted in my upbringing. There was never a day that I didn't see things, and not until I was a little older. And of course, there was racial slurs and oppression and injustice. And at that time, my dad was definitely one of the freedom fighters for many people. But I come from an ancestral generation of freedom fighters. But like Jess Went, I was the first woman in my generation to be able to go to, undergraduate to pursue graduate education and, to pursue education. And I think at so many levels, from undergrad to medical school to training, and almost a daily participation, especially in institutional settings, not to name one hospital or health authority, or I've witnessed it so often that it just became a daily battle. But what I chose to do was speak up about it. And it takes courage, you're right, but you become an outlier, but then you create a culture of acceptance and intolerability. So what are we willing to tolerate? And I think you bring people together. And I've got a lot of allyship, I must say. People are saying white European ancestry. I've got a lot of allyship and a lot of people that are not of my race, but understand humanity and to take a stand against injustice or oppression. And I think we need to cultivate those spaces. And obviously, I'm very aware that I'm only the second woman of color, ever in this position at the presidency. So it is something that obviously permeates my existence. And that's why I'm so passionate about it, because I also do believe that racism is a social construct, and it's a healthcare injustice and inequity that we need to confront and embed and proclaim our stance against it. Because just like Tatiana said, that we treat heart failure and complicated comorbidities, but this is one thing that, we can all simply start by just changing our awareness and how we show up and how that. And it's interesting because people will say, you sharing your story, oh, and now I see it, I understand. But just take a little deeper look at your patient in front of you, and sometimes it'll surprise you. There's a lot of diversities of origins, and we've been ingrained. The immigrants' mindset is to be ingrained to just do the work and don't get noticed, right? Continue to do it quietly, get to the top and lead. But unfortunately, we need to be the ones now to also unmask, like Jess once said, is to confront the biases and the way we participate that is unacceptable moving forward. So it's going to take all of us to change that culture. And I think we could have stories for days if we really shared all our living experiences. But I also speak of some of my colleagues that have come forward and have had some really glaringly, unacceptable happenings with their families, and the advocacy standpoint, as well as knowing my family that's received subpar care and witnessing because they thought they had a language barrier, or because they thought they were less of a citizen, and not until they were aware that, oh, there's a physician involved in the care, or that's their children, that did they change the way that they provided care. So I'll leave it to Tatiana if she wants to speak.
Yeah, thanks, Dr. Desange. I think it's helpful to think about it in a couple ways. And one way I would say that is really important is, we talked about feedback and wanting to know about creating an environment where our patients feel comfortable talking about their experience. But I think, the first place to start from a systems issue is being able to hear and address our own colleagues, because we know that there is, a power imbalance. But if there is a power imbalance already pre-existing, it becomes quite challenging. So I challenge all of us to be able to address these issues and being open and hearing it to our colleagues, because if we can't do it amongst ourselves in our profession, it doesn't bode well for addressing it with our patient and clientele. And then the second thing that I would say about a shared lived experience, and this is a lesson for me, was just my own experience of, seeing patients during the racial upheavals that followed the death of George Floyd. And I had, the experience of sitting with mothers who, who asked me, like, how are you doing? And so I think, the reflection that our patients want to know that we are thinking about it as well. And so that is a big lesson to me. And I think in the most prescient of terms, one of the mothers that I worked with shared with me, and this is, I think, something that I always stays with me, is she said, I don't want you to think for a minute that when I see George Floyd dying, that I see him. I don't see him. I see his uncle, and I see my son, and I see his grandfather. So I think it's really, really important to think of the overall clinical, the social context that we're living in, and not, and just be aware that this has a direct trickle down effect into our, what we're seeing in our clinical rooms. And so that is my lived experience, is that A, our patients want to talk about it, and B, it's imperative that we open our psyche to it. And the fact of the matter is that this mother had said, we've seen 5 physicians and since George Floyd has died, and no one's addressed this. Yet this is all my kids talk about at the kitchen table. They are so over COVID, but they want an explanation for this. And on every website, there's all this anticipatory guidance on how to talk to your kids about COVID. And she said, there is not a single place where I can go to explain to these children what is going on in our world. And so I think when it comes to what my individual experience is my individual experience is that I don't have any training, and there wasn't an adequate curriculum for me to deliver care that was very prescient and very real, sitting there in front of me. And so I think I would urge you, when these situations occur, to then move this up to systemic level and say, hey, where are we? Like, why don't we have anticipatory guidelines? Why don't we have something in place? And also, I see my colleagues who may themselves also be experiencing microaggressions. I think when we think about physician health and wellness, this also needs to be an integral part of physician health and wellness, is addressing this, because before we are physicians, we are humans.
So it first starts with, within the profession, let's talk about it. Let's take the lid off, and let's deal with it within ourselves, within our team. And then we can generalize it to the larger system. Now, I've given up trying to answer all these questions, and Dr. Hobson has advised me that there is no way that we could ever cover all the questions that are coming in, so because they're coming in fast and furious. So we are committed to provide answers to all the questions. We might not be able to answer them all online. So this question is directed to you, Jasmine, Dr. Gazda. I sense that you don't feel that we can be unbiased when it comes to how we view patients of different races. Can you expand on that? Unmute.
It's sort of like a regular conversation, right? Unmute. to be trained in, and I'm a psychiatrist, and not even in supervision. There was not one time when a supervisor ever spoke to me about what it felt like to be the only brown resident in that experience, and what this meant between me and my patients. There was no place to discuss it. So one of the issues about training is how comfortable are we in supervision and in other kinds of experiences to give a physician, our colleagues, an opportunity to talk about these kind of things and share them, and to make it to make it a discourse. Power and privilege is very well alive and well in our profession. And our hierarchical way of thinking is really, I see the young people challenging that. I see them asking for mentorship. I see them challenging the way things were done before. And I think this is wonderful. We really have to offer the young people spaces in supervision and in training to really be allowed to talk about it. If they can't talk about it with each other, how are they going to talk about it with their patients? How are they going to welcome them and welcome the mistakes and say, I'm so glad you told me that, and to begin to open up the conversation rather than to suppress it? Because this is what I see my colleagues doing. Either they ignore it, they look the other way, or they're deeply offended that you wanted to discuss it at all. And their ego is very, very hurt, because we in medicine idealize ourselves. And may have seen the recent article about Mother Teresa not being such a saint, and how terribly difficult it was for people to get over the issue of idealization. Well, I think we should all take a lesson in that, because we tend in medicine to idealize many of the things that we do, and we've really got to get over ourselves. I mean, in the real world, we all have the same illnesses as our patients. And that's how that is why Tatiana can say that she can ask the little girl, how did you feel? Because she's been there. And she knows if somebody doesn't ask her, that child will never share it with somebody outside. That's the question that you hope a teacher might ask, a mentor might ask, an auntie might ask. But this is our role, how to really have a conversation with our patients and with each other about this very important area of change.
Thank you, Jasmine. That's an incredible message. We need to have the conversation. We need to open this space, because it does impact our patients' health in a very negative way. So I have to wrap up at this point. I'm going to ask each speaker to articulate a key message that they want to bring to the audience. And so I'm going to start with Ramneek.
So I think in closing, I just feel that my ABCs are just the awareness, the action, and the allyship, the 3 A's. If we can go home with that and lead with intention, and every day remind ourselves that we're imperfect humans on a journey, but we can only meet our patients as far as we've met our own selves.
Thank you. Thank you for that powerful message. Tatiana.
Yeah, I think just simply because I'm a pediatrician, it's all about development. But essentially, racism has a lifelong developmental trajectory that has, very serious physical, mental, and developmental effects, not only for the individual in front of you, but the generations that follows.
Thank you, Tatiana. We know that the ACEs impact people's health and longevity to the degree that it decreases their life expectancy up to 20 years. And systemic racism is one of those big overflowing ACEs. So we do need to look after that from a healthcare provider's perspective. Jasmine, your last pearl.
I would say that patients are our teachers. So if we are seeing that our patients are suffering from the effects of racism, which they are, and we've seen it in COVID, we've seen it all through our professional life, we have to take responsibility to be part of their allyship, and not as a word, but it has to actually be taught and spoken about in our training. How to be an advocate, how to engage with community, and that is also part of it, and it's also part of our self-care, to understand how that our own human limitations hurt us, and we have to be able to turn to our colleagues for support in that. It's very important.
Thank you. So in concluding, I'm sure you would love to continue to hearing more from this incredible panel. And again, I commit that we're going to answer all the other questions that were left unanswered. But we've reached 90 minutes and it's time to wrap up. I would like to express my sincere gratitude to this exceptional panel, Dr. Ramneek Desange, Dr. Jaswan Gazda, and Dr. Tatiana Sotinja. You are all very dedicated healthcare professionals and you were excellent panelists. Thank you for taking time from your very, very busy lives and heavy responsibility to present and answer the audience's questions tonight. I'm sure everyone has appreciated it. I also want to acknowledge our hardworking UBC CPD staff, without whom the delivery of these webinars would not be possible. We won't be here. So thank you to Bob Blumen, Brenna Lynn, Bruce Hobson, Catherine Young, Stephanie Amehu, Steph Din, and Naomi Almara. Please take a few minutes right now to complete the attendance and evaluation forms that were emailed to you in order to obtain study credits and to provide your feedback on tonight's webinar. Please note that this webinar is accredited up to 1.5 main pro or section 1 credits. Please also be aware that you will be receiving a follow-up email containing tonight's webinar recording, as well as the link to the previous one on the impact of anti-Indigenous racism on healthcare, and any other resources that were mentioned here, and there are a ton of them. Finally, I want you to know about another free webinar that we're offering in our Child and Youth Mental Health Substance Use webinar series coming up on Wednesday, May the 25th, supporting children and youth presenting with challenging behavior that is perceived as aggression. This is emerging more and more coming out of COVID, that more children and youth and families are presenting with mental health challenges. We have another excellent panel organized for you with Drs. Gordon Neufeld, Dr. Jane Ryan, Susan Baer, and Stacey Ye, and with Linda Ueda moderating. Thanks again, everyone, and a good night to all of you. Thank you.